Good morning. We're here in the podcast for Urologic Integrated Care. My name is Victoria Bird, and I have a guest today, Dr. Manish Amin, PhD physicist specializing in MRIs. I am doing this podcast just from demand. So many colleagues have asked me, hey, how do you read MRIs? What is your approach to MRIs? Yeah, so we figure we put a little podcast and share our experience with MRIs. By no means I'm replacing any of the pirates or any of the usual ways of reading MRIs on interpretation, but this is more or less how I approach MRI reading.
This is truly needed in the field. This is great that you're doing this.
Yeah, thank you. I think it helps a lot of people just kind of visualize numerical values. So let's go to the first slide. And again, next slide. Great, some of my disclosures. Next slide. So today we're going to learn all of these objectives, and we're going to go in order, and hopefully we'll be able to teach you a little bit about basic anatomy for the prostate first. So next slide. And we're going to start with a video. So first video. So a little bit about MRI reading. It's important to know the structures that you're reading. So I have a software that I'm working usually almost every day, and it's MIMS software. Now it's being acquired by General Electric. And what this software allows you to do is allows you to characterize different areas. So right now I'm tracing the peripheral zone. The dark blue has traced the transitional zone. Above the dark area, the transitional zone, you can very clearly see the dorsal venous complex. And I am about to trace also the neurovascular bundle in rectum and also the bony structures, including the ischium and the pubic bone structures. This is very helpful to do, and usually when I trace my prostate for my own MRI, fusion biopsies, or any different type of ablative technology, I trace the urethra as well as the seminal vesicles just to help with co-registration during my procedures. Next slide. Okay, great. So you can also train your artificial intelligence software to trace this, what will be your preference in this case. You know, we have the transitional zone area trace, the peripheral zone, and also very clearly we have the anterior horns of the prostate, also the neurovascular bundles, rectum, ischium, pubic bone. Below you see the coronal view of the T2 weighted images with the bladder and the apex of the prostate, and of course the urethra. Next slide. So you can also trace muscles. For example, we can outline the obturator internus muscle, the levator muscles. I'm also added the pectineus muscle there for you, just to be more complete. Next slide. And if you are doing any type of ablative technology that involves any tumors in the apical region of the prostate, it's very important to understand the anatomy and also be able to see very clearly the levator muscles complex, the urethral muscles, the intrinsic and sphincter, in order to be able to spare those muscles during your treatment. I found personally that patients that have tumors that impinge into the apex close to the sphincter, we've been able to successfully ablate about 1/4 of the area close to the sphincter without causing any type of incontinence in our patients. But this is very important to know the anatomy and to outlining on your MRI while you're doing ablations in the apical region. Okay, next slide. So this is a little bit more about normal anatomy. You see that the very dark symmetric layer on top of the prostate, that's just an anterior fibromuscular layer. It's symmetric, and don't confuse it with a tumor because you will see this dark area in your MRIs. And now these slides is types. This imaging comes from the internet, and if you need any references, I will be happy to give you some references. Now, the anterior fibromuscular layer is different than anterior carcinoma. So you can see a T2-weighted ADC, diffusion-weighted image, and dynamic contrast enhancement series, where you can see the anterior carcinoma rising from the transitional zone, going anteriorly, and you can see it as a very bright image on the diffusion-weighted image and a dark features in the ADC. Next slide. Now, obviously, this is, again, also from the internet, but also I want to point out that you can see very obvious locally invasive prostate cancer. So it's demonstrated stage 3 and 4 prostate cancer, and some into the seminal vesicles, and some that are into the actually the levator muscles. So this is stage 4 and stage 3. Next slide.
Horrible looking gland.
Yeah, it is really, I mean, it's like one of those that you don't see very often.
Yeah.
Yeah, so that's why it's definitely a good feature to see. Well, now I'm going to talk to you a little bit about the qualitative PIRAS reading versus quantitative. We're going to start with qualitative reading. Next slide. Okay, so, and then this is where Manish probably knows more than I do, but as far as how did, and I think he actually knows Dr. Behrens, who is the person that published the first version of the PIRAS, which is Prostate Imaging Reporting and Data System. But from what I understand, Manish, this was created to basically be an international language among radiologists, correct?
Yeah. I'm creating a standard for which radiologists could then reference and look at to know how do you properly score MRIs for prostate is really valuable. And Dr. Behrens, who I wish to know in person, but I've only read about him and read his research. But he really wanted to come up with a standardized way of analyzing MRI for prostate. And there's been multiple versions of this. As PIRADS version 1 came out back in 2011. And since then it's been modified and changed to really help radiologists and then the urologists understand from an MRI perspective what this gland really is showing, what it looks like.
That's great. Yeah. And this has become the standard of care as well, how to assign PIRAS by a board certified radiologist. There has been many publications, unfortunately, that demonstrate that there is not only intra-reader variability, but also inter-reader variability, and I think that's a limitation. Yeah, it means it's subjective. Basically, your human eyes look at the images, and they kind of characterize the images in a grayscale.
I mean, pre-coffee versus post-coffee, I don't know.
Exactly.
You might have some variability there, too.
Exactly right.
Yeah.
All right, next slide. Okay, so this is peripheral. So we're going to go over the PIRAS reading score on the peripheral zone first, and then we'll go over the transitional zone. But as you can see, this is how the score goes from 1 to 5. And, of course, I think most urologists are familiar with PIRAS reading and knowing that PIRAS 1 and 2 are deemed to be likely benign, PIRAS 3 is questionable, and PIRAS 4 and 5 is mainly cancer. So when you look at these images, number 1, for example, and this is actually, we were talking about this with Manish because they could have choose a better image. Actually, the peripheral zone in a T2-weighted image should be completely bright, white bright, without any tinge of gray. And that would be a PIRAS 1 in my book. But I chose this just because it's a little different. And what this is demonstrated this dark region on the T2-weighted image in the middle, and the T2-weighted image on number 1, and that's likely prostatitis. But there is nothing really bright. So personally, when I look at an MRI, I immediately look at the diffusion-weighted images. What about you, Manish?
Yeah, I think that's absolutely correct. Between getting a quick glimpse at the T2-weighted image and then right to the diffusion images, just to see localized, where should I really start investigating? Is this a 3, 4, or 5, or anything like that? Exactly.
So when we're looking at 1 and 2, the diffusion-weighted image, which is the middle column, there is absolutely nothing really bright. There is just shades of gray. Nothing pops out as a tumor, as a bright tumor. In PIRAS 3, you can see there is a little bit of a lighter aspect on the peripheral zone there in the circle. And then when you look at the ADC mapping, it looks fairly gray, but, then the determination is not there to be completely benign or a tumor, so that's why it's deemed PIRAS 3. Now, when you look at the diffusion-weighted images on PIRATS 4, you can see that bright peripheral zone tumor light up, and then absolutely you can see it on the T2-weighted image in the peripheral zone, and also in the ADC mapping, you can see it as a dark spot. And of course, in PIRATS 5, you have a tumor that is already more than 1.5 centimeters by definition as a PIRATS 5 that has a bright signal in the diffusion-weighted image, dark on T2-weighted, and also very obvious on ADC mapping. So that's the essence of a peripheral zone PIRATS reading. Let's go ahead to the next slide. Now, this is a transitional zone, and so now we can see in one side has 1, 2, and 2. Now, I see that the slide doesn't show it, but the very first image is a PIRATS 3, and then the next image is a PIRATS 4, and then the next image below is a PIRATS 5. So, and I'm sorry, cut off a little bit on the other side. But basically, you can see the transitional zone is a little bit more challenging because you're going to have these dark areas, which are your benign glandular tissue. And the key thing is, again, look at the diffusion-weighted image. What is it telling you? Is there a bright area there to indicate any tumor there? So, now, ADC mapping and diffusion-weighted image reveals really nothing isohomogeneous and hypointense in PIRATS 1 and 2. Now, when you look at the transitional zone in the other side where the circles are, you can start seeing some brightness. So then you have a PIRATS 3 there in the very first row, outlined by a circle where you can see an area on the transitional zone that is bright. It matches your ADC mapping and your T2-weighted image. Below that, you see a large area again. It seems to be like in the area where the anterior horn is in the peripheral zone on the right side. And then also you see it characterizing the diffusion-weighted image, semi-bright, and then also in the ADC mapping. Now, very clearly now in the bottom two images, 2 rows, you see a lenticular, they call it lenticular or non-circumscribed, synchronized homogeneous, dark area on the T2-weighted image. You see the brightness on the diffusion-weighted image, and again, you confirm it with the dark area on the ADC mapping. Same with the lowest visualized imaging on the bottom, where again, you see that, again, the area is very dark on T2-weighted image and ADC mapping, and it's bright on diffusion-weighted images, but it's over 1.5 centimeters, and that will deem it a PIRATS 5 lesion. Okay, next slide. Okay, so for quantitative reading, it's very different. So I feel like PIRATS is challenging depending on, again, before coffee or after coffee and how you see the grayscale.
Right.
There's a few caveats on why this has not been taken off instead of PIRATS, and we'll go over that. But so the actual ADC value, which is what I use for mainly when I approach my MRIs, is inversely correlated to the likelihood of clinically significant cancer. And ballpark, and I'm going to kind of talk to you about it, but this is ballpark. Values above 900 micrometers square per second are considered likely benign, and below 750 micrometers square per second is likely malignant. And peripheral zones are different than transitional zones. So less than 750 in the peripheral zone, possibly cancer. Less than 650 in the transitional zone, possibly cancer. And then I have a red, bold, yellow, and this is extremely important. So this depends on the scanner and the protocols that you have. So how the images were acquired, the B values, what kind of scanner you have, a Siemens, a GE Philips, and the protocols. So this is extremely important. So the most important thing is that you need to get to know your own scanner. So the way you worked in practice is you have a scanner. You have you have your MRI, and then you have your pathology. And then you can say, okay, for my scanner, these are the range of Gleason 3+3 my MRI ADC values, I see 600 to 500 to 600. And that may vary, and there's many factors that modify that variation. So you need to get to know your scanner. So if you talk to any radiologist, board-certified radiologist, including very famous board-certified radiologists that are experts on prostate, they will be like, you need to get to know your scanner. You need to know your B values and what the ADC mapping is for your specific scan for the specific tumors. What do you think, Manish?
Well, I wanted to ask you actually on this. This is impressive, right? That you've been able to identify this from your patients. But how long in the beginning, when you first started to adopt MRI, how did you get to understand that these are the ADC values I need to look for? Did you reach out to radiologists, or how did you figure this out?
I have a very excellent mentor. Actually, he's one of the I think he's considered one of the best prostate radiologists and in the field, and he actually showed me about the ADC values, and then I did some research on it, and including we have an IRB approved research through our company that we looked at all of our patients' ADC values, and we found that using 1.5 Tesla Siemens scanner and a 3 Tesla GE scanner, even though they were completely different scanners, the ADC values will still hold for certain grades of tumors, 6, 7, 8, 9, and 10. And when we did the analysis, at the beginning, when you look at them, there was great variation. But then when we did a secondary analysis to see if it was significantly different, it wasn't. And we were surprised because these are different scanners, different protocols, different places. And but there's still too much variation to approve this. Okay, this is the range for this Gleason. But now that we have been using our Siemens 1.5 scanner, I know my scanner and I know the ADC values that correspond to benign tissue, to Gleason 3, Gleason 6. So this is very helpful to know your own scanner, and it holds. And then, but anyway, so this is quantitative reading. I find it very helpful because sometimes you get MRI readings, perhaps they say PIRAS 3, and we had a few of those, and we're like, okay, what are the numbers? So then we're able to pinpoint the numbers, and we're like, okay, I see that there is something in the anterior area that they didn't even consider. That is ADC values of 300. So it's very interesting to see all of that because it allows the plain urologist like me to be able to say, oh, okay, well, look at that. That's looks significant. And I actually had feedback after giving a course at our State of Florida Urology meeting. I got some feedback from some urologists. They're like, thank you for letting me know this. It's helped me a lot, being able to understand what my patient's MRI looks like, what do they have. So it's been very helpful. So that's what we're doing this podcast today for my colleagues and some of the students that have reached out to me. But basically, with quantitative, I'm going to have you go back to the previous slide just for 1 second. So this is based on numerical values. I use only ADC values, but I only use a minimum ADC value, and I don't do average. And you know why, and I know why. But the reason why I think is because you can have an ADC value of 50 and one of 1,000, a few pixels or voxels right next to it. So easy to learn. I have a few students training, and they come to learn how to read MRIs and learn about this new methodology. Actually, it's not very new. It's been there, and now I just saw a few publications this year in 2025 on how to use ADC values post ablative technology treatment, which is very interesting. And next slide.
Well, that's a really good point, actually, that for active surveillance, qualitatively, you can say, oh, the tumor looks a little worse, but if you have numbers, it might make it easier for the urologist to say, maybe it's time to actually intervene now. Now we've been surveilling it for a little bit. I see these numbers going down. I see the PSA rising. It might give you just another metric that you can use over time as well, not just for a single time point.
There is some academic institutions that are actually employing that, and I know that hopefully in the next few years or less than that, we'll have some sort of methodology for that. Now, so these are very important basic concepts of prostate MRI that and we're so blessed to have Dr. Manish. I mean, because he's brilliant, and
I am, aren't I? Okay.
he's been a friend of mine for many years. Yay! So we're going to go ahead and have him take over and kind of explains to us what is a T2-weighted image, how are they made, what is diffusion-weighted image, what is ADC mapping, and what does he think about an accurate model in the future to make, the reading of MRIs more accurate and easy and straightforward. But not only that, because if you're able to quantitatively characterize MRIs, that's the whole basis of teaching an AI software to read MRIs accurately.
Yeah. I'd love to chat about this. In fact, MRI is what I did in school. I really love studying it. I love studying applications of it and optimizing sequences, really analyzing it for the purposes of bringing it to medicine and making it better for physicians to actually be able to use this kind of stuff. So I'll start off with T2-weighted images.
Let's go to the next slide.
T2-weighted images are...
next slide.
Next one, yeah.
Hey,
that's me.
There you go, Manish. Yeah.
That's me, president of MRIQ Consultants. I've obviously background in MRI physics. I got my PhD in physics with the subspecialty of MRI physics from University of Florida here in town. But ever since then, I've been working in the prostate space, really trying to look into how to bring this to both interventional and diagnostic for urologists. But yeah, next slide. I'll start off with T2-weighted images, and I think the next slide actually has some images here. Perfect. So these are examples of T2-weighted images. Generally, I've been asked this: T2-weighted, T1-weighted, proton density, DWI. What do all these things mean? Physicists and scientists in general, we love to just use numbers and letters for a certain metric. T2 is, I think we use T because it's a relaxation time. But T2 is just a time constant related to water molecules that are in a certain media. So water molecules that are in a cup of water have a certain T2 value. It's just a relaxation time related to magnetic fields and all that. It can get a little too complex, but it really doesn't need to be. What we see is in the prostate and really in the entire body, this time constant that's measured using the MRI machine, it varies depending on the local media. So water molecules that are in the peripheral zone they're in a different environment than water molecules that are in the transition zone. And the way to really measure that environment is what we call T2-weighted imaging. MRI, and I'm a huge proponent of MRI, I think T2-weighted imaging is just one of the strongest images you can collect to really get a good understanding of the anatomy. You can see the muscles, the prostate, the rectum, the neurovascular bundles, the bladder super well. And
I see that you have a 7 Tesla there. Tell us a little bit about that.
Yeah. So here's an example I grabbed from one of the papers I was reading, comparing 3T versus 7T for a prostate. And this is just to give you an example of how the MR that you use, the properties of it, can impact the quality of the images that you get. You can see with the 7 Tesla machine, using the exact same resolution, the exact same pixel size, you get a much clearer, sharper delineation of the prostate. You can see what the suspicious lesions, both at 1 and 2, on the 7 Tesla machine, way better than you can on the 3 Tesla machine. But the magnetic field strength is not the only property that affects the T2-weighted image. On that bottom row, you'll see different properties. Here, they just change the size of the voxels. But, by changing properties and your exam card, you can really get different levels of contrast. Somehow it looks a little bit more grainy on that right-hand side, but I feel like, you can see a lot more contrast than you could with that image you see on the left, which is very high resolution, but very blurry.
That's impressive.
It looks really nice. I don't know if we ever get a chance to do 7 Tesla prostates, but there are not that many of those floating around.
I don't know if we have any 7 Teslas in Florida.
Jacksonville, I'm sure Mayo Clinic.
Oh,
Mayo
that's
Clinic.
Great to know.
Yeah.
Okay, and then what about diffusion-weighted image? Well, next slide.
So next slide, yeah. Diffusion-weighted images, that's my bread and butter. I love diffusion-weighted imaging.
Next slide.
That's actually what I worked on in school. And so what is diffusion MRI? I love this slide because it really helps show a little bit what it is. On the right-hand or on that side, the glass with the water glass,
Yeah,
whatever side
the
that
latter
is. You just see an empty glass full of water. But I love to use this example. If you can imagine diffusion MRI, diffusion really is if you take a drop of like red dye and drop it into water, you see it dispersing over time, right? That is what diffusion is. And with MRI, we have this ability to measure that property in the body, in different types of tissue. Now, you're not dropping a dye anywhere, obviously, but you can almost consider the magnetic field to be dropping a dye of magnetic field almost, and just seeing how does that water molecule move around. As you see on the top, those are stained images seen under a microscope. As you get cells that are more and more tightly compact, those water molecules have less and less room to sort of roam around. And diffusion MRI is able to accurately sort of measure that. Benign tissue, you have healthy cells that are probably well spaced apart, connective tissue in between. The diffusion will, the water molecules are able to diffuse around pretty easily. And so if you were to measure that using MRI, it would look like good radiodiffusion, which is going to be a darker signal, meaning water molecules can move far away.
That's great.
As you get to more malignant tissue, all that tissue is more compact. And because of that, the water has a more tortuous nature in its path, and it can't really move as nearly as far away in the same time frame. And
so it will appear like a bright area on the diffusion-weighted image. Right. Great. So we'll go to the next slide.
Mm-hmm. So this is just an example showing how, as you have like these compact malignant cells in the second row, you'll have, cells that are more tightly packed and the water can't really move. You'll have a low ADC value, and this is a little mnemonic here on the right. No, I don't call it mnemonic, but just a little image that shows you if the ADC is bright or dark, and if the diffusion weight image is bright or dark. For normal cells, you'd expect the ADC to be bright, and you expect the diffusion weighted image to be very dark because the water can move. Mm-hmm. The ADC is rate of diffusion. If that rate of diffusion is really, really low because it can't move, then you'll have a dark image, and that's what you see on that second row. Mm-hmm. In fact, the next slide actually, I believe, kind of shows this a little bit. Just a nice pictorial I found online that shows as you go from like normal tissue to malignant proliferation, like you see these cells are more tightly compact, they're irregular, they form more solid surfaces, and water molecules have a hard time really traversing that. And diffusion MRI measures exactly this, and we see a strong correlation between diffusion MRI and prostate cancer.
Absolutely. And so that's, I think, for urologists, for clinicians, I think that for me, diffusion weighted image is the best thing. It's just go and then see what lights up, what exactly is there that I need to pay attention, mm-hmm. especially if I'm limited on time and I'm seeing many MRIs. I'm like, okay, where is it? Yeah. And then I can sort out, okay, this is the T2 image, this is the ADC mapping, and then this is the ADC number. So mm-hmm. great. So, okay, what about ADC mapping then?
So diffusion weighted, because there's so many images and it is quantitative, you can mm-hmm. make this ADC calculation. And could you go to the next slide? So we'll go over ADC mapping. I think on the next slide I have a little pictorial that goes over this. Mm-hmm. So diffusion weighted imaging, one thing people will realize about this is we have this B value. B value is just how much are you going to measure that motion of that water molecule. If it's moving a lot or it's moving a little bit, the higher the B value, the more sensitive you are to that motion. So what we do to do this ADC mapping is we acquire the same diffusion scan, the same area, using different B values. And the different B value basically is just measuring different lengths of diffusion. That's a crude way of saying it. I'm sure the MR physicists out there are yelling at me right now, but it's good enough for...
Well, this is just for clinicians. So
this is a good way of understanding it. Yeah.
Thank you.
And so we acquire it at different B values. Mm-hmm. And when we do acquire the same signal at different B values, we can plot that signal across the B values, and that's what you're seeing here. Just a plot of the signal versus that B value for each individual pixel. And when you fit a linear line to that plot, to the log of that plot, you get what's called an ADC map. And that ADC map is then basically just an apparent rate of diffusion. Basically, how quickly, if you dropped dye in water, how quickly would it diffuse into the entire cup? That's your rate of diffusion. It's the same thing here. How quickly does that water molecule diffuse around in the space that it exists?
And you can actually calculate B2000s and use that for your ADC mapping as well?
Well, those calculated B-value images are nice because they help really, really accentuate where you see tumor. But there are definitely certain B-values we like to use to do this ADC mapping. There's at very, very low B-values, and as you get to very, very high B-values, the fitting of that B-value to the signal is not so simple as a straight line like this. There's a lot more complexities that get involved. But luckily, in the urology space and for prostate cancer, those complexities at the really low B-value and high B-value don't really seem to be as important. Really, that middle range of B-values that we use is what we use to calculate our ADC, and it seems to have a really good correlation with tumor.
The MRI is just full of information that I think in the future we're going to be able to find more and more features that help us be more accurate. Next slide. Aha.
Ooh, quantitative. Okay. I'm a big proponent of this. So, what we generally do right now is we look very qualitative. You had alluded to this multiple times. But here on the next slide, you'll see, this is what you may be able to pop up. And as a urologist, you want to get through your studies as quick as possible because you have tons of patients in the clinic and all that. Could you go to the next slide, please? But this is what you're looking at on your images. You'll see qualitative images that are great, and you'll be able to hopefully get to the point where you're quickly popping these images up, and you can say, okay, I think there's tumor here, there's tumor here. Look at Xeon diffusion and T2. Where is it localized to? How is it adjacent to the surrounding structures? What I think is really interesting to me is that there are more. ADC is a good quantitative map, but there are other quantitative maps as well too. We talk about T2 weighted images, but how about a map of T2 values?
Exactly.
Because every single pixel, that tissue has its own T2 value. So there is a concept called MR fingerprinting, and we'll show it here on the next slide. I think there's a lot of interest in this and other types of metrics as well too, where we can take these metrics, quantify actually the value that exists within the prostate in different pixels. We can look at the ADC value, the T1 value, and the T2 value. T1 just being a different type of relaxation. And these are just quantitative numbers that we can then hopefully feed into an AI model that makes it even quicker, even easier for urologists to be able to pop up an MRI scan, see where there is something that they're worried about, and then correlate that with potential cancer.
That's wonderful.
Yeah.
That's it. The goal, right, is being able to do things efficiently, but also very accurate.
Yeah.
Especially with the physician workforce shrinking and then the advent of AI that's going to help us, figure out all of these features so we can be more efficient, but also accurate, so we don't compromise that. So we're going to go over some quantitative reading. So we already talked about what ADC mapping and what is ADC with Dr. Manish. He was able to elucidate that very well. So we're going to go over a few examples. So let's go to the next slide. Now, again, so this is just a pictorial, and then we're going to go through some videos on how I approach the MRI. So in this particular example, we have the very first row, you can see the T2 weighted image, the axial, and then you can see a tumor in the right peripheral zone. Very clearly, you can see that. And in the diffusion weighted image, you can see that it lights up. But in the ADC mapping, you can see that this value, and the value actually, I'm sorry, that's a typo, it should be micrometer square per second, is 576. And this tumor corresponded to a Gleason 3+3 in pathology. In row B, you can see there is a tumor on the left anterior horn. Very obvious again, bright on diffusion weighted image, but the ADC values are lower now. They're in the 400s. And this corresponds to a Gleason 3+4. And in the C row, We have, again, a tumor in the peripheral zone, very posterior there on the right side, going midline, bright with diffusion weighted image and a value of 78, which is really low, and this was a Gleason 4+3. Again, these are images from the internet, and I'll be happy to give you the references. Now, we're going to go through a video here of a high-risk cancer. As you can see, this is something that we're outlining here. You see the prostate, peripheral zone. The tumor is coming out, actually, of the prostate. And this tumor corresponded to a Gleason 4+4 tumor. The ADC values here were 278 micrometer square per second. The pathology also demonstrated, actually I want to, so when I do this, so you see that I'm brightening up the resolution of the image. And when you do that, so if you're in a hurry and you want to really make sure that you're seeing tumor will never lighten up. So even you lighten up the screen, you make it brighter, only the benign tissue will stay bright, and then the tumor will stay dark. And in this particular case, this was a T3A, so it was an extracapsular extension, Gleason 8, and the tumor minimum ADC value was 278. Okay, we'll go to the next example. This is a median lobe tumor. This is a patient that had two different prostate biopsies. PSA was 10 and then 19, and by the time I saw him, his PSA was 39. And basically, his tumor really was on the median lobe. So using our software, we outlined the tumor, we outlined the prostate, and it's interesting because so we lighten up the, I guess that's a nice trick to do to be able to see the peripheral zone, transitional zone. And as you scroll, you can see the very dark spot on the median lobe, very dark. So the ADC values here were 67. The minimum ADC value was 67. By the time we did the biopsy, this was a Gleason 5+4 equal 9. The patient elected to have a prostatectomy. He had a negative metastatic workup, believe it or not, with a PSA of 39. And he had extracapsular extension and T3 disease already. So this was a challenging biopsy. We did an MR fusion biopsy on this patient, and it was done transrectal. The gland itself was 90 grams, and we were able to reach with a long needle this specific area in the biopsy. And we're going to go to the next slide. There's another tumor in the peripheral zone. And in this particular case, so the ADC values were not that low, but let me see here. So then you can see the anatomy. You see the T2 weighted image. And we can scroll a little bit faster maybe just to see the, yeah. All right, well, okay, so there you see a tumor right there on the peripheral zone. And again, I lighten up, put the image brighter so I can see if there's any other tumors besides that one. But that clearly is tumor.
It jumps out on the DWI.
It jumps out. And then also if you look at, so it's interesting because sometimes you don't see tumors in very clear on T2 weighted image.
Yeah.
So you look at the ADC mapping and you're like, wow, there it is. So you can see ADC mapping. And then also it jumps out on diffusion weighted image. Yeah. And this was fascinating interesting because the ADC values were only 424. So we're like, okay, and the Gleason score was 4+3. But then when patient had a prostatectomy, he actually had also Gleason 5 in the tumor. It was a criviform and introductal features. And the pathology was T3B with seminal vesicle invasion and extracapsular extension. And all our patients are counseled extensively for different treatments, surgery, radiation, or ablative technologies. And this patient really just wanted to have surgery followed by radiation, and he knew what he was dealing. Very smart person. So, okay, so we're gonna go to one more video here, and this is a tumor in the anterior zone. So, and anterior zone tumors, it jumps out at you. The fusion-weighted image is super bright there. And we can continue with the video, so if you want to play the video there. So basically, anterior tumors are unusual, but they're there. And again, these are patients that come after 1 or 2 biopsies, and they come for a more detailed biopsy. So I always get an MRI. Sometimes, if they already have an MRI, I use the MRI they already have. And if there is something like an anterior tumor, I don't repeat the MRI and just go ahead and do transperineal biopsies. Now, as far as biopsies, I do both transrectal and transperineals, depending on where the tumor is. When the tumor is anterior like that, I do transperineal biopsies because it's an easy access to that tumor. And in this particular case, you can see that the tumor is very close to the edge, the margin of the prostate. These end up being the ADC values. The minimum ADC value in this tumor was 374. And the Gleason were 4+3. It has 60% Gleason 4 in the pathology. We also do something called the Decipher to look at the genomics, and in this particular case, it was a high-risk genomics, and this patient is a newer patient, still having a workup. So let's go ahead to the next slide. Okay, so those were all high risk or very nice featured tumors. We're going to just do some graphics here for intermediate disease. Next slide. Now, this is unfavorable Gleason 4+3 tumor, and you can see that the ADC min was 373 micrometer per second, and then you can see the diffusion-weighted image, then very, very bright. What do you think, Manish? When you look at this, does it look like more like a Pirates 5?
Oh yeah. The thing that jumps out to me though is, I can just see myself, if this is just part of your workflow, you could just pop these images up and just really quickly window and once you get skilled at doing this, a lot of the times you get good at looking at the diffusion image and then going back to your T2 weighted image to see, does it make sense? But I think it provides a really good tool. It just jumps out almost every single time.
Exactly.
Now, it does miss it sometimes, of course.
Yes, it does.
Which is why this is not replaced anything. It is simply just an additive tool to add to help you take care of your patients. Mm-hmm. But just being good at looking at these diffusion scans, I don't think it's difficult by any means. I mean, you picked it up rather quickly, but
I think it's when you look at numbers. So what I found very helpful is to have these 4 series together in one screen. So I have the T2 weighted image, the coronal, the ADC mapping, and the diffusion weighted image, and then I can scroll back and forth on my coronal. Sometimes, depending on the size of the peripheral zone, I scroll on my coronals very fast just to screen on the peripheral zone, just to look at the entire prostate, anterior posteriorly. But most of the time, yes, I go to the diffusion-weighted image on axial and then just look for the bright spot. In this case, yes, this was the brightest, and that was the lowest ADC mapping corresponding to that bright diffusion-weighted image. So this person ended up having, with high risk Decipher, and the next patient is another Gleason 4+3. I'm sorry. Go back. Yeah, that's the same as there. So then you can see that on the T2 weighted image. Was a little bit challenging seeing anything, and I'm not sure if this was a defect from the scanner, or sometimes I get patients that come from different places and they have their own MRI discs. So when you look at the T2 weighted image, you really can't see much. But then when you look at the diffusion weighted image, you're like, aha, that is tumor there on the peripheral zone on the left side. And then you look at the ADC mapping, you see something. So that's what helped me in this case when I look at this MRI, which I didn't really see much on the T2 weighted image. But this ended up being a Gleason 4+3 with high risk decipher.
And you can definitely tell with the T2 weighted image there's definitely pollution of noise, whether it be, supplementation, like iron supplementation. Sometimes when patients take that, might corrupt the noise, corrupt the images. But even maybe it's an older scanner, maybe it just wasn't as
maybe
good
the
as what you're
Faraday
relevant to.
cage wasn't good enough, or had a little leak. So tell us a
Yeah.
little bit about the Faraday cage, so people know.
So just so people understand how MRIs work, MRIs work off the same bandwidth. It's frequency, frequency, energy, electromagnetic waves, magnetism. They're all kind of the same thing. Light, for example, it has its own frequency and wavelength, has its own magnetic field, everything. Magnetic fields for when we do MRIs, they operate on the same frequency range as like AM/FM radio, and so there's a lot of AM/FM radio just around us.
Yes.
And so generally, what we have to do for MRI is we have to build these cages, these rooms that can block out all signal outside of the room. I don't know if you've ever brought a phone into an MRI room. Probably shouldn't do that anyways. But if you do, you'll probably immediately lose signal because of that Faraday cage. Yes. It's built there, and it's built in a specific way just to make sure that it tries to keep out as much signal as it can, as much electromagnetic radiation as it can, just from the outside world. So that the only thing that you're measuring from that magnet is the energy created and read by that magnet.
And tell us about the non-ferrous materials used to build these Faraday cages.
Most of the time it's either, I think copper might be the cheapest, copper, aluminum. But usually they just have these copper, aluminum shielded cages that they just build into the walls.
And that basically blocks every single electromagnetic wave from the outside, so you can have pure readings on the MRI scanner.
Exactly.
Yeah, so we were wondering about that on this particular T2 weighted image just from the noise.
Yeah, and that happens. But what I find really interesting is even with the polluted T2 weighted image, you'd expect those kinds of pollutions to affect all the sequences, the diffusion, the DCE, T1, T2. And even then, the diffusion image is pretty powerful, and I assume for you it helped you determine, what is the next step for this patient.
Exactly. It allowed us to at least identify an area that looks suspicious.
Yeah.
Yep. Okay, next slide. Okay. This is another patient that has an area with ADC mapping of 449, and again, this particular scan, the diffusion weighted image was limited. So I know it looks dark, but I show this on purpose because sometimes you'll be like, okay, why is this not? And it's just whatever they choose to put in the disk. So just or the data that you're allowed is like, okay, well, but anyway, so we actually just looked at the T2 weighted image and the ADC mapping. The diffusion weighted image in this case was not very particularly helpful, but because we know about ADC mapping numbers, we're like, okay, even though it didn't have this bright spot, we're going to go ahead and biopsy. And this was a Gleason 3+4 with high risk decipher. Next to it, we had, can you go back to the slide before? Okay. This was an unfavorable intermediate risk. And again, this was a very small area, as you can see in this in the transitional zone. It's a Gleason 3+4. The decipher was 0.5 times intermediate, unfavorable intermediate risk tumor. And it's very small, but we found those ADC values, 365 micrometer square per second. As you can see, it's a very small tumor. But indeed, it was a Gleason 3+4. It's clinically significant. This person had a rising PSA, and that's what kind of we tipped off. Okay, go ahead and do a biopsy, and we found this tumor. Let's go ahead and go to the next slide. We're going to look at some low risk disease now. Next slide. Okay. So again, we have. So these are the ones that are a little bit difficult because nothing looks really bright, nothing looks really dark. How do you approach this?
Well, this is tough, right? Because I think when you have these 3+3s, just the shapes and the formations of these cells, they don't really cause there to be disturbances in diffusion sometimes. And so a lot of times, Gleason 3+3s, they may not really have that much of an impact on diffusion, which it just makes the reading tough, but also goes back to speaks to, obviously MRI is not the only tool that you use. These are tough images to.
They're tough images. I think the
determine.
only thing that helped me is like finding that ADC value. It's like, okay, I see 634 biopsy Gleason 3+3, and of course these patients go on surveillance, and one below was 608, and again surveillance patients that wish they have family histories, they want to know if they have cancer or not, and we find it, and these patients are just happy that they know, and then just changing their lifestyle, like their diet, exercise, and modifying all those environmental factors that makes them more successful, not to develop any kind of issues with their prostate cancer, and most of them don't.
And that's really good. Even here you see that correlation with a slightly lower, ADC value. There is some specificity to that as well too. It wasn't as low as some of the other ones you've shown that have shown obviously clear cut cancer.
Exactly.
But this does give you a lot of indication of where it is. And one thing I'd like to point with ADC mapping, you see every pixel of every single cell in that prostate.
It's amazing.
Sometimes with biopsies, depending on how many needles you use, you're mapping the prostate out, but sometimes you might see an area that looks a little bit fuzzy with like one dark spot in it.
Yep.
Sometimes it's hard to really track, but with MRI, it's just an added tool that gets
the MRI, inboard biopsies will be great. Unfortunately, it would be nice to have them MRI inboard biopsies for accuracy, but the rest of the world, I guess we don't have the ability to have that. So I think most urologists have an ultrasound, but it helps to have some fusion biopsy software. Let's go to the next slide. This is another one, again, ADC values in anterior horn. We found a small tumor, Gleason 3+3, ADC values of 664, and the next one was another tumor in the transitional zone. The ADC values are on the 600s, again, the Gleason 3+3, low risk. Next slide. Okay, and then some patients are, I have some patients actually, I shouldn't say, the radiologists or they're doctors and oh, look at that, that's dark. And I'm like, oh, don't worry about it. And why? Well, because it's not tumor, it's just prostatitis. So we're able to determine that looking at the diffusion weighted image, which does not light up at all, and the ADC mapping. So this is prostatitis. Okay, next slide. Now, we're going to talk a little bit about metals in the MRI field strength. So a little bit just background, and this is my interpretation. Let's go ahead to the next slide. Next slide.
Sorry, it's not working right now.
Oh, that's okay, no problem. There it is, okay. So we talk about different MRI field strengths, and we've noticed in the clinical practical world that unfortunately when patients have metallic objects like hip prosthesis or UroLift clips, that by having a 3 Tesla MRI, you see less on the T2 weighted image, perhaps a little bit less than a 1.5 Tesla MRI. Why is that?
Well, the effect of something like metal, it's just aggregated by the strength of the magnetic field. So as you have a stronger magnetic field, the artifact that's caused by the metal will then grow. And the only way to grow is sort of spatially. So the artifact that you'll see will just be worse and worse. Now, the types of artifacts we see, metal artifacts are one of those where certain sequences are very, very bad, but certain sequences also work. For example, your T2A sequences should still look very good in the prostate, but your diffusion sequence, you may see some signal blowout where you don't see the image at all because of that metal artifact.
And we have an example of that. So in this case, we're looking at, so the very first figure is geometric distortion, and that's some of the metallic object effects. You can also see, that's geometric distortion. That's when you see the whole image shift. The second one is a spatial misregistration. The third one is signal voids. where you actually see in that prostate, you see some Urolift clips and you see them dark. It's actually called the blocks. I think it's as a MRI terminology, dark
so.
blobs or something. I think so in a article. And the last one is distortion of the thermal map. And let's go to the next slide. So, Manish, you were mentioning, yes, so this is a particular subject with hip prosthesis in the right and also Urolift clips. And you can see a little bit of the difference on the T2-weighted images, the same patient who had a 3 Tesla MRI and a 1.5 Tesla MRI, just to be able to see the prostate a little bit better. But you can see really, truly that the ADC mapping, the dynamic contrast enhancing, of course, diffusion weighted is all gone. Really, I know some patients want Urolift clips, and I do Urolift clips for some of my patients. That they just come with the preconceived, hey, I want this specific, and it's their choice. And I counsel them very, very carefully. Listen, you will get the Urolift clips and it will work great, have good outcomes. But the MRI quality, if you need to have it in the future, is gonna be altered. So sometimes for those patients, they're like, well, okay, then I want to get an MRI before or something. I don't know. So those are kind of subjects for discussion, but just a word of caution on using any metallic objects in the prostate.
And you want to also, the other thing to think about is obviously if you have choices of where that patient can get scanned. Obviously, if they have Urolift clips or a hip replacement or something, getting scanned on 3 Tesla magnet will be worse off, but they might still be able to get scanned on 1.5 and still get pretty good information. So sometimes having those options, if you have the option to send your patients to certain places, might be pretty beneficial.
So less magnetic field strength is going to be less distortion of the image.
Yeah.
Okay. All right, next slide. Well, we've gotten to the conclusion. And basically, we found that MRI reading following quantitative ADC values, it can be simple. The minimal ADC values is very helpful. So if you have time to scan your MRI, look at the diffusion weighted image, where is the bright spot, and then go into the ADC mapping and see what value is that. And then sometimes when you use mean of lesion surface area, then it's not as accurate because you don't even know the mean of what, right? You can make, I see that radius of 0.5 centimeters each side of the mean, or what. There could be something that is ADC value of 1,000 next to 67, and then that alter your complete ADC value. So you need to characterize this. And actually, we had that conversation with Manish in the past about how can we make this work. Like if we will have a way to use ADC min for these tumors. And Manish came up with an excellent idea of having perhaps look at all the minimum values and pick the first quartile of minimum values and use an average of that as a way to grade tumors with ADC mapping.
Yeah, what I've realized working with people like yourself is, you guys are just busy.
We talked about this like a year ago, so I don't know if you remember.
I do. I absolutely remember this. We talk about, you plot all your ADC values and you look at the bell curve. You look further down the bell curve.
Exactly.
But, talking with you, one thing I've realized is I can look at an MRI image for one patient, obviously not my patient, I'm not a medical doctor, but for one patient and spend an hour looking at that and seeing what I want to see. You guys we have to find a way to make this a more efficient process.
Yeah, we do. We do.
And so I think as part of that, I thought it made sense. We worked on this. Maybe, if we have a certain area, a certain region, you could plot those pixels and just get a good glimpse of what the bottom half of that bell curve looks like.
That has helped a lot, especially in clinical practice, is just to be very efficient. And, I definitely look at, the PIRATS reading, and that guides me go to the diffusion weighted image, ADC mapping, and then actually I do have a big monitor in in my office where I have the patients go over their own MRIs, and I explain to them the whole thing, and then they have the biopsy, and then we go to treatment. So the patient is very well informed.
That's gotta be great for the patient. I'm
It
sure
is
they
great. They love
and
it.
hear
And
that.
some patients that are, themselves physicians, they find it fascinating.
Yeah.
And I have a last image here in the conclusion, that showed the MRI of a patient that had pretty advanced cancer, but it really lights up.
5+5.
This Gleason 5+5. Yes, and the patient had been on ADT for a while, but anyway, so it's very obvious. But I wanted to show that last image. Okay, well, I think we're done. Thank you so much, Manish.
Yeah, thanks.
It was so
Thanks for
wonderful
having
having
me.
you over. Yeah, thank you. Take care.
All right, see you guys.